this morning keynote lecture on individualization. We will gonna listen the next presentation, which is on individualized dosing algorithm for polytropin delta by Manuel Fernández. The floor is yours.
Thank you. Okay. Well, good morning. It's a pleasure for me to share this data with you. Okay, thank you. These are data coming from a study in which individualized polytropin delta was used in a long GnRH agonist protocol. And we present data from live birth after fresh transfer and cumulative live birth after fresh plus cryotransfers. I have no conflict of interest to disclose. Well, as we all know, in 2015, it was described for very first time the individualized polytropin delta protocol for antagonist protocol. So the data we are presenting right now are just the first one with individualized polytropin delta, but in a long GnRH agonist protocol. This is a subset analysis of a European randomized phase 2 dose range trial, which has been very recently published in this year, in 2022. And all patients were randomized in this trial, which is called Rainbow, in this original trial. All patients were randomized to receive individualized polytropin delta plus different doses of choriogonadotropin beta, and one of the subgroups was the control one, and they received polytropin delta in an individualized algorithm, but they only received placebo additionally. So in fact, the only drug, the only medication they received for control ovarian stimulation was individualized polytropin delta. Something important to highlight is that also the big trial is prospective, randomized, placebo control, etc. The subgroup of patients we are analyzing today, this data, are not a control group of agonists with individualized polytropin delta versus antagonist polytropin delta. They are just the subgroup of these patients at the description of the data, and they were in a long GnRH agonist protocol with individualized polytropin delta. The study question was if this individualized polytropin delta regimen, based off, as you know, anti-Mullerian hormone and body weight, was effective and safe. We did the follow-up to the live birth rate after fresh transfer and the cumulative live birth rate after frozen thaw transfer. Initially, the plan was to include patients for the cryotransfer within 1 year after randomization. But as you all know, COVID pandemic came, and well, it was prolonged for 3 months more, the timing for including cryotransfers. So it was a little more than 1 year after randomization to include the cryotransfers. Well, let's review some patient characteristics. The mean age was 36 years. The inclusion criteria were from 30 to 42. The patients were in the initial Rainbow trial. They were divided into 2 subgroups from age, from 30 to 37 and from 38 to 42. The mean anti-Mullerian hormone was 15, and the mean antral follicle was 14. And let's review some data about the stimulation and ovarian response and oocyte blastocyst. The cancellation rate was low, about 3%. The mean duration of stimulation was a little more than 10 days. And these are some data I would like to highlight because they are usually higher than previous data. The mean number of oocytes was 12.5, and the number of mature of metaphase 2 was close to 10. The mean number of blastocysts was 5.1. The mean number of good quality blastocysts was 3.7, and the mean number of cryopreserved embryos was 3.3. Okay, we reviewed the data from 92 fresh embryo transfers. More than 1/3 of patients had at least one cryotransfer. The total number of cryotransfers was 58, so the total number of transfers, the fresh plus cryo, was 150. 95% of the transfers were single embryo transfers, and 5% were double embryo transfers. Well, let me explain a little this graphic, which initially can be a little confusing, but let's go in detail. This figure illustrates the time point, days after randomization, for all transfers and for all live births after those transfers, fresh plus cryo. Digits represent the order of the transfer. So the number 1 is the first transfer, the number 2, the second transfer, etc. You can see in blue the fresh embryo transfers, and in red the cryo transfers. The number 2 is the second one, etc. All subjects are sorted by time to achieve the live birth. So you can see in yellow the live birth after fresh transfers, and in green you can see the live birth after cryo transfers. They are shown as a percentage of all patients, so you can see here the days and you can see here the cumulative live birth rate. To summarize this data in a more clear way to see it, you can see here, taking into account the timing and the live birth rate in fresh and the cumulative rate 1, that more or less after 40 weeks after randomization, after starting stimulation, the live birth rate was 43%, and within less than 2 years after starting stimulation, after randomization, the cumulative live birth rate was 58%. In this another graphic, you can see the implantation rate compared or taking into account the embryo quality score. You have in yellow the fresh transfers and in green the cryo transfers. The bubbles size and the number inside reflects the number of transfers performed in that case, in that line. So if you see, it's very visual. Most of fresh transfers, implantation, the embryo who implanted, most of them were the top quality embryos between 5AA and 4AA, or 5AA, sorry. 5AA to 5BB. And most cryotransfer were a little lower quality, between 4BB and 5BB. And well, this is probably one of the most important data from this trial, and probably we will discuss later in the time of questions, which is the hyperstimulation syndrome in the different degrees. In total, we found 11.5 hyperstimulation syndrome, which is high. 6 of them were early, 3 mild and 3 moderate, and 3 of them were late, 3 moderate and 3 severe, 2 of them with hospitalization. The total number of patients included, I think I didn't say before, I didn't mention, was 104 patients. So, in conclusion, the data coming from this individualized folitropin delta dosing in a long GnRH agonist protocol, in patients, the patients included had a range of anti-murine hormone between 5 and 35. The data we found were that peristaltic stimulation, we described a mean number of oocytes of 12.5, a live birth rate after fresh transfers of 43%, a cumulative live birth following fresh plus frozen transfer of 58. The cancellation rate was low, 3%. The overall hyperstimulation syndrome incidence was 11.5%. This hyperstimulation syndrome incidence reflect the slightly higher ovarian response, number of oocytes, number of embryos, of total embryos, and number of good quality embryos and cryopreserved.
We need to allow some time for questions, so please conclude. Thank you.
Thank you. This is the conclusion. The data's conclusion are that individualized folate-repeat delta dosing seems to be effective and safe in a long GnRH agonist protocol. So thank you to all the people working in this trial. Thank you.
As we wait for the first question, I have a question. How can a protocol be effective according to the title when there is an 11% OHSS rate?
The question is, if we consider effective?
Yes, I'm wondering, there is an effectiveness and there is a safety.
Yeah.
Always that we need to take into account. So when we have 11% OHSS rate, it's extremely high. So how can we really call this protocol as an effective protocol?
Yeah, it's a good question. It's just the question of the data. In fact, I think that for that it's important to remember two things. One of them is that this is not a controlled trial with agonist versus agonist. This trial is being performed and is being finished, but there are no still data available. Of course, I think that, as Dr. Melo shown before, it's a matter of balance between higher results, higher hyperstimulation, higher number of oocytes, embryos, and live birth, higher number of hyperstimulation syndrome. I personally do not feel confident with 11% of hyperstimulation syndrome. I think it's too much. I think this is not acceptable nowadays. So the point, in my opinion, is just a matter of selecting the patients. I think we saw before that maybe we are not still sure, evidence is not still very clear, but probably the long GnRH agonist protocol trends to achieve a higher number of oocytes and probably a higher number of embryos. So we need to select, because maybe for patients normal close to high is not an appropriate.
Thank you. Thank you. I will interrupt. Professor Hughes?
Yes. The question is indeed to which extent you can explain this very high hyperstimulation rate. 11% is extremely high, so is your conclusion then that the algorithm doesn't work in this set of patients?
Well, I take advantage of the question just to finish the one before. So in my opinion, the point is to better select the patients, because GnRH agonist protocol, most of us do not use daily, but in a lot of centers, in a lot of countries, it's still widely used. And probably the point is to select normal to low, or probably low responder patients, but that needs to be confirmed with further randomized control trials.
It's a concern. Thanks.
One more question.
Did you look at differences whether increasing HCG administration gives you better pregnancy rate, better embryo quality rate, lower OHSS rate?
You mean HCG?
Yeah.
Well, in fact, that's the previous trial. This is not the one we are discussing today. And it's published, has been published very recently in Rainbow, and it was not a good correlation. I mean, the HCG did not increase the number and the quality. In fact, in some doses, it decreased.
Thank you.
Okay. Thank you.
Welcome.
Thank you. So.